Hello, and welcome to an evidence-based approach to assessing thyroid disorders, a video produced in conjunction with the UC Davis School of Medicine. In this video, we'll give a quick overview of the evidence-based physical exam, discuss an evidence-based approach to physical diagnosis in hyperthyroid disorders, and provide a video of a UC Davis Master Clinical Educator demonstrating high-yield physical exam maneuvers that every UC Davis graduate should know, as well as discussing the evidence behind them. Hand washing before and after each physical exam has been well studied and shown to reduce morbidity and mortality in the hospital and the clinical setting. Listed here are some basic tenets for performing a physical exam and assessing different thyroid disorders. And while these provide a useful basis for our general physical exam, today we're going to talk about a different approach. An evidence-based approach to the physical exam begins with a diagnostic question. For example, does this person have chronic anemia? To answer the question, you first estimate a pretest probability, which is essentially your best guess as to how likely you think this patient is to have the pathology in question, based on aspects of their history, presenting symptoms, etc. It's generally expressed as a percentage. Using this as your starting point, you choose an evidence-based physical exam maneuver, which, depending on whether the test is positive or negative, will feed back on your original hypothesis, giving you a new post-test probability, as demonstrated in this figure. For example, if you don't think that your patient is anemic, giving them a pretest probability of 20%, but then you discover conjunctival pallor on exam, that really changes your thinking, giving you a much higher post-test probability. How much a given physical exam maneuver changes your pretest probability depends on the sensitivity and specificity of the test, which in this case is expressed as a function called the likelihood ratio. You can see in the figure how a positive or negative likelihood ratio can affect your pretest probability either a great deal, for example if you have a positive likelihood ratio of 10 or more, or barely at all, for example a likelihood ratio close to 1. Let's explore how to use this when you're concerned that one of your patients may have a hyperthyroid disorder. So in evaluating the patient with suspected hyperthyroidism, again we start with our pretest probability, which is our best guess as to whether or not we believe this patient does have hyperthyroidism and how sure we are that we're right, expressed as a percentage. And again, this is based on aspects of the patient's history, such as their age, past medical history, recent illnesses, medications, etc. And I want you to know that almost all of the data for these physical exam findings, which are pretty compelling, come from essentially one big study of about 880 patients. So a pretty robust data set, even though it's only one study. And highlighted in yellow, you'll see multiple physical exam findings that are predictive, have great positive likelihood ratios and really good negative likelihood ratios. But I have to say, the ones that really jump off the page are some of the eyelid findings. Eyelid retraction, which has a positive likelihood ratio of 33.2, and eyelid lag, which has a positive likelihood ratio of 18.6. So learning how to look for those is going to be really key in making this diagnosis. So I just want to show you a picture here. The top one in A is a good example of eyelid retraction over on the patient's right eye, where you see the white of the sclera above the iris. In the middle picture, picture B, you see a great example of eyelid lag. This sign is elicited when you ask the patient to look downwards. On the unaffected side, the patient's left, the eyelid follows. On the affected side, the patient's right, the eyelid lags behind the movement of the eye, leaving behind a big swath of the patient's sclera above the iris. The bottom picture is a classic depiction of exophthalmos, or the thyroid stare, which, along with eyelid swelling, is classically associated with Graves' disease, as opposed to just any cause of hyperthyroidism. And I thought that that was an interesting point, actually, that eyelid retraction and eyelid lag are things that you can have from hyperthyroidism from any etiology. But proptosis and eyelid swelling, those are specific for Graves' disease, the autoimmune type of hyperthyroidism. Now I want to make one quick point here, and that's about picture A. Now you can get kind of a false positive for eyelid retraction in a patient actually that has contralateral ptosis. And this arises from the fact that the patient is volitionally trying to open his or her eyes, but the side that has ptosis, they're not able to do that. So they're trying extra hard, and it can look like they have lid retraction on the side that's actually normal. And the way to assess this is actually to cover the eye that appears normal, the eye with ptosis, and see what happens. If they still have lid retraction, then it's a bona fide lid retraction concerning for hyperthyroidism. But if the eye goes back to normal, then they actually probably have a contralateral ptosis rather than an ipsilateral lid retraction. Also note that lid retraction and lid lag can be unilateral in hyperthyroidism. It does not have to be bilateral. This is just a quick figure illustrating how to elicit lid lag on physical exam. So what you do is you have the patient follow your fingers with their eyes, just like a normal extraocular muscle exam. And as you move your finger down and the patient is instructed to move their eyes down, normally the lid will follow. If there's a little bit of a lag where you're able to see the sclera above the iris, then that's lid lag. Here's an example. Observe as the patient looks down, you are able to see the sclera above her iris. Her eyelid lags behind the movement of her eyes. Also note that the patient is affected on only one side here. Here is the right. Again, you see the lid lag over on the right side as she looks down. So here you can see several other physical exam maneuvers that were included in that one large study I mentioned. And you can see some of them are very predictive of hyperthyroidism. For example, the classic fine finger tremor, which has a positive likelihood ratio of 11.5 and a negative likelihood ratio of 0.3. Here's UC Davis Master Clinical Educator Dr. Mark Henderson demonstrating a technique for assessing a fine finger tremor.
The most common physical findings of hyperthyroidism is a fine tremor. Rather than assess for a tremor by having the patient hold their hands up like this, oftentimes what we use is this piece of paper trick, which is a more sensitive way to detect tremor. So in this case, we have the patient hold their hands up and put a piece of paper on the hand, and then look around the edges of the piece of paper, and you can see, actually particularly here, the tremor is amplified, and you're much more easily and much more able to see the frequency of this tremor. You can see that versus looking at his hand, you hardly see anything. Right? So,
other evidence-based physical exam findings include moist and warm skin with a positive likelihood ratio of 6.8, and tachycardia in this study defined as a pulse greater than 90, which has a pretty good positive likelihood ratio at 4.5 and a very good negative likelihood ratio of 0.2. Again, all very useful tools in assessing the patient who may have hyperthyroidism. Here's Dr. Mark Henderson again, demonstrating a general approach to the thyroid examination.
Examine the thyroid, we do so from behind the patient, so that can be approached in a number of ways. So you usually want the patient sitting, and we like to give them a glass of water because we're going to ask them to swallow, and they may have dry mouth. So when I approach the thyroid, I feel for the largest and firm landmark, which is the thyroid cartilage. You can feel that on yourself, which is where your Adam's apple is. I start with that, which is right here. I can feel the prominence here. This is the top of the thyroid cartilage. Then I usually bring my fingers down. I follow the thyroid cartilage down to the next little bump. There's a little valley and then a bump. That next bump is the cricoid cartilage. Again, it's a firm, almost like it's a very much a smaller, like a half a ring, the cricoid cartilage. So that's here. So we've got the thyroid cartilage, followed down in the cricoid cartilage. And so between those two cartilages, there's a squishy membrane right here. It's the cricothyroid membrane. So this is where you would perform like an emergent tracheostomy, right? That's where you would insert the trach. So right below, so that's where I put my fingers. I slide down, excuse me, to the cricoid cartilage, and then I'm going to have the patient put water in their mouth, and then have them swallow, because under the thyroid, cricoid cartilage is the thyroid gland. So swallow for me. Yeah, so excellent. Maybe take one more drink. I'm going to try again. So I'm feeling the thyroid go under my finger as he swallows. So one more time, David. Yeah. So right here, again, the thyroid comes up and under my fingers, and I feel the contour of it as it crosses my fingers.
Next, I wanted to direct your attention to another one of these combination tests, in this case, the Wayne Index, which has persisted since 1959, and a positive test has a positive likelihood ratio of 18.2, and a negative test has a likelihood ratio of 0.04. Again, this is extremely useful in ruling in and ruling out hyperthyroidism, and it's such a good scoring system that they haven't really introduced any revision since it was originally introduced, nearly 60 years ago. Let's take a look at the criteria. So you'll notice that the scoring system is a little bit more complex than the Bailiwick's and Zalewski scoring systems that we looked at with hypothyroidism, but essentially it's the same idea, a collection of symptoms and signs that are classically associated with hyperthyroidism. Things like palpitations, tiredness, excessive sweating, etc., as well as signs such as lid lag and fine finger tremor that we discussed earlier in the video. And this has persisted through the years as being very predictive of both ruling in and ruling out hyperthyroidism in patients. So let's take a look at how this plays out on McGee's evidence-based physical diagnosis calculator. We select hyperthyroidism from the drop-down menu. It gives us a range for average pretest probability, but again, you'll be choosing this based on your patient's history and presenting symptoms. And let's start by just taking a look at pulse. Remember, a pulse greater than 90 had a positive likelihood ratio of 4.2 for hyperthyroidism. So on the calculator, it takes your probability of this patient being hyperthyroid from 40% to nearly 80%. That almost doubles the likelihood that they're going to have hyperthyroidism. Now, let's say their pulse is less than 90. Remember, that had a negative likelihood ratio of 0.2. It takes the probability that this patient is hyperthyroid from around 40% to just over 10%. So either way, the pulse that you see on your intake form is going to really inform your thinking as to whether or not this patient has hyperthyroidism. Even if you're more sure, let's say you have a pretest probability of 60% or even 70%, if this patient's pulse is less than 90, it makes it way less likely that they're going to have hyperthyroidism. So let's take a look at another physical exam finding, fine finger tremor. Remember, that had a positive likelihood ratio of 11.2. So if you have your patient extend their hands and you see a fine finger tremor, then it takes your likelihood from around 40% to 90%. Again, that's a very strong positive likelihood ratio that significantly changes the way you think about your patient's pathology. The negative predictive value of fine finger tremor also significantly alters the way you think about it. If you're 50% sure that the patient's hyperthyroidism and they don't have a fine finger tremor, then now you are just over 20% sure. That's less than half as sure as you were before. So let's look at eyelid lag, which has a positive likelihood ratio of around 18. Again, it brings your pretest probability from 40% up to over 90% as a post-test probability. Very, very predictive if you have a positive test that this patient may have hyperthyroidism. Now we look at eyelid retraction, positive likelihood ratio of 33.2. Again, you're nearing 100% for your post-test probability for hyperthyroidism. Positive Wayne index, positive likelihood ratio of around 18, similar to eyelid lag. And then a negative score on the Wayne index. Remember, that has a negative likelihood ratio of 0.04, meaning that if you have a negative score on your Wayne index, even if you were 70% sure that this patient had hyperthyroidism at the beginning, you are now 10% sure after going through that scaling system. Here's a visual illustrating some of the different physical exam findings that we've talked about today, along with their associated likelihood ratios and the percentages by which they change your pretest probability if positive or negative. In conclusion, let's review 4 take-home pearls from this video. First, when you're evaluating a patient you suspect may be hyperthyroid, start by looking at the vitals and the patient's general appearance. That includes assessing their pulse, their skin to see if it's moist and warm, and their eyes to see if they have the classic thyroid stare or any lid retraction. Next, take the time to learn to do a good examination of the thyroid gland, including assessing size, texture, and landmarks. Third, a good neurologic exam is an important part of the assessment for any suspected thyroid disorder. For hyperthyroidism, this includes the assessment for fine finger tremor with outstretched arms and an examination of the extraocular muscles, during which you can look for lid lag. Finally, keep the Wayne index in the back of your mind as a good assessment tool for ruling in or ruling out hyperthyroidism.